Now, our first speaker for today is Dr. Traci Murakami. She graciously agreed to speak in Dr. Kawada's spot because he couldn't join us for this session. Now, unlike last week's speakers, I have not yet gone to Traci, but there's still time, so I plan on it. I have a keen interest in the gut microbiome, so I love to hear about the GI tract. Traci is a proud JABSOM alum, and we are very grateful that she returned to Hawaii to practice. So please welcome Traci.
All right. Hello, everyone. So today I'll be talking about the aging gut, common GI issues in seniors. So what is gastroenterology? Gastroenterology is a medical subspecialty that specializes in the digestive organs, which include everything from the esophagus, which is our swallowing muscle, to the stomach, the liver, the gallbladder, the pancreas, and the large intestine and the small intestine. So all of these organs are involved in what medical subspecialty that I practice. And why is it important in senior citizens is that, as we know, the population aged 65 and older is expected to double by 2050, and about 30% or a third of all medical visits to your primary care physician or family medicine doctor are for some sort of GI gastrointestinal complaint. What are some issues that are sort of unique to seniors? Well, when I see older patients in the office, we often do a functional assessment. So we want to see how independent people are in their activities of daily living, which include cooking, shopping, cleaning, doing chores, and caring for themselves. Is there a caregiver present or a family member present that can kind of help give more information or that manages medications for the patient and things like that? Dementia, depression, and delirium, the 3Ds of geriatrics, can definitely all affect someone's nutritional status and how they present with their symptoms and how they respond to therapy. A lot of times older folks don't always present the same way for certain diseases. So, for example, if an older person has an infection, they don't always have a fever, which is something kind of interesting because there is an age-associated decline in sensory and autonomic reflexes. A lot of times patients are on a lot more medications, and that can kind of complicate the diagnosis and treatment of the patient. When we're older, we have changes in the way our body metabolizes medications, and that can affect the kind of medications that we use to treat certain diseases. And, we have a lot more medical problems as we get older. How does aging affect the GI tract? So actually, surprisingly, the GI tract has a very large functional reserve capacity. What I mean by that is that if you compare the colon or the stomach of a young person compared to someone who is 103, you can't tell the difference just by looking at the pictures. They'll look pretty much the same. And so aging really has very little direct clinical effect on most of GI functions, but it does have effect on the physiology. So, for example, with aging, we can get some loss of teeth and loss of saliva, and that can cause some difficulty with chewing and swallowing. As we get older, the driving force of the tongue can diminish and weaken, and that can cause issues with swallowing as well. And there can be reduced strength of the motility or the contractions in our esophagus, stomach, and intestines that can lead to slow clearance of food and liquids. With age, there can be loss of appetite and indigestion, and how this occurs is that there's a loss of protection of the stomach lining, so decrease in the mucosal barrier and cell proliferation in the stomach wall, so that can lead to increased risk of infections in the stomach or sensitivity to medications like ibuprofen can cause inflammation in the stomach and things like that. There can be delay in the emptying of solids and liquids, as I mentioned before. Constipation and changes in the rectum can occur with slowing of your colon motility and thinning of your anal sphincter muscle, as well as reduction in the strength of the squeeze pressure in the rectum and impaired sensation in the rectum as well. So this is kind of just a summary slide, just kind of going over everything I mentioned previously. So what are some of the common complaints that we hear in GI from our older patients? Dysphagia or difficulty swallowing is common. Feeling of indigestion or dyspepsia. A loss of appetite, also called anorexia. Constipation, which can either be sort of infrequent bowel movement frequency or difficult to pass stools or very hard stools. And fecal incontinence or a lack of control over bowel movements. So let's talk about difficulty swallowing, dysphagia. So swallowing disorders occur in about 16 to 22% of those over age 50 and is also common in patients in the nursing home setting. Symptoms can be coughing or throat clearing during or after meals and a sensation of something stuck in the throat or what we call globus sensation, or eating meals very slowly or choking sensation. The most common cause is neurologic, such as after a stroke. Some common causes of difficulty swallowing can be things like anatomical. So if you have a tumor that could be blocking the passage of food, things like Parkinson's disease or Lou Gehrig's disease, which are neurological, can affect swallowing. Inflammation in the esophagus caused by acid reflux or medications, or motility problems with the esophagus, because esophagus is a muscle. Medication side effects can also cause some difficulty swallowing as well. A lot of times, certain systemic diseases such as diabetes or neurological disorder, as I mentioned, can cause reduced contractions and motility of the esophagus. Treatment is usually having a physical therapist called a speech pathologist work with you, and that can be useful, especially if it's due to a stroke causing the difficulty swallowing, because they can teach you different techniques and how to modify your diet and lifestyle so you're able to swallow better. Common medications that can cause inflammation in the esophagus include medications for osteoporosis like Fosamax, supplements such as iron or potassium, as they're pretty large pills. Antibiotics such as tetracycline as well can cause inflammation in the esophagus. So how do we evaluate difficulty swallowing? We have what's called a barium swallow, which basically takes an X-ray of someone swallowing the barium, and it's a contrast substance, and it gives an outline of your esophagus. Sometimes we do refer patients to ear, nose, and throat specialists to take a look at the oral pharynx. And then what I do is, I do endoscopy, so I do a camera study looking inside at the esophagus and the stomach to assess for problems there. Manometry is another test that we can do in GI that measures the motility of the esophagus. And so it's almost like a pressure map, and you can see sort of how the pressure and the muscle is squeezing as a patient swallows water. And it's done by putting a catheter in through the nose and having the patient swallow 10 sips of water. And we can see sort of how the water moves down the esophagus. Acid reflux disease or gastroesophageal reflux disease can happen as we get older because there can be a weakening of the lower esophageal sphincter muscle that kind of keeps the stomach contents down into the in the stomach and prevents them from coming up into the esophagus. But really the prevalence of reflux is not really different compared to younger populations, and is about 20%. Complications from having a long-term acid reflux can be inflammation in the esophagus or a predisposition to getting esophageal cancer in the future, or changes in the lining of the esophagus, as well as ulcers can occur if the acid reflux is not in check. So how do we treat acid reflux? Well, a lot of times if there is some warning symptoms like difficulty swallowing, bleeding in the stools, or painful swallowing or weight loss, then we would do a upper endoscopy to check the integrity of the esophagus using the camera to see. There's also medications such as proton pump inhibitors, which decrease the amount of acid that is produced in the stomach. But there can be some side effects with using antacid medications. Lifestyle modifications, so trying to avoid eating spicy foods, trying not to eat late at night before you lie down, things like that can also help reduce acid reflux. There's also a surgical option to treat acid reflux as well, that can be done. So indigestion, or what's called dyspepsia, can occur, and the most common causes of this can be ulcers in the stomach, acid reflux, stomach cancer, and sometimes we don't find a cause of these symptoms, and we call that functional dyspepsia, and that's usually after we have done all of our studies and we still can't find a reason for the symptom. Bacteria overgrowth, or having too much bacteria living in our intestines, can cause bloating and sometimes cause decreased motility of the intestines, and that can also lead to indigestion as well. So how do we evaluate indigestion or dyspepsia? A lot of times we will take a more aggressive approach because there's a higher risk of having cancers, as we get older. So we would like to take a look with the camera, with the endoscopy. Sometimes you can do breath testing as well to look for bacterial overgrowth in the intestines. So a breath test is where you ingest sugar. And the sugar, like glucose or lactose, is metabolized in our intestines and fermented, and it gives off either a hydrogen or methane gas as the bacteria ferments the substance. And we can measure that gas production, and that can kind of tell us if there's too much production, then that means that perhaps there could be an overgrowth of bacteria in our intestines that could be leading to indigestion. So treatments, usually we will try some antacid medication in case the discomfort is from acid reflux. Sometimes you can also give antibiotics if we consider that there could be maybe too much bacterial overgrowth or a common infection in the stomach called H. pylori, which we can test for. But if you have these conditions, we can treat them with antibiotics. Sometimes we can use a medication to increase the motility of the stomach, and that can kind of help with indigestion as well. Probiotics, there's not a lot of randomized controlled studies looking at the benefits of using probiotics, but they can be helpful in certain patients with treating indigestion. A lot of times we'll tell patients to try to get more exercise because that can improve your gut motility, as well as stress reduction and things like that as well. And also improving constipation or diarrhea, which I'll go into. So loss of appetite can occur, as I mentioned, with aging. A lot of times it is a decreased appreciation of food and a poor appetite that can lead to decreased hunger as we get older. A lot of times we're not as physically active as we were when we were younger, and that can cause sort of a decreased energy need and a decreased intake because we're not as active. We do lose body fat and lean body mass after age 70, but the real problem of nutrition in the elderly comes from reduced oral intake of food, and not really a problem with the GI tract itself. So there's a lot of reasons for poor intake as we get older. Everything from social isolation to not being able to cook as much or shop as much for the things we need to cook, poor dentition, and having some physical handicaps as we get older to being able to cook. Changes in our taste buds and our smell can also affect our hunger. As well as dementia can also cause poor intake. So we do have a mnemonic for assessing weight loss in older folks. It's called Meals on Wheels, and basically it kind of goes over all the many different causes of weight loss. Everything from oral problems, having no money, having medication side effects causing weight loss, as well as having thyroid problems, and shopping and meal preparation problems. So it's a good mnemonic to keep in mind. What are some causes of involuntary weight loss? Can be loss of appetite, muscle atrophy as we get older because we're not as active, or inflammatory effects of disease. So certain diseases like cancers or chronic kidney disease can cause an inflammatory effect in the body and cause us to lose weight unintentionally. So a lot of medications, as I mentioned, can cause decreased appetite. Common medications include medications for the heart, like digoxin or amiodarone, which are antiarrhythmic medications. Medications, supplements like iron can also sometimes cause decrease in appetite. A lot of acids that we use to treat acid reflux can cause a decreased absorption of nutrients. And laxatives and diuretic or water pills can also cause us to lose fluid and electrolytes. So you've heard of Ensure and other supplements that we sometimes encourage patients to take to increase their caloric intake. We do prefer to feed patients orally or enterically through the GI tract instead of feeding people through an IV. A lot of times it could be something as simple as removing dietary restrictions to get somebody to eat more. And definitely one way to improve weight gain would be to increase someone's protein intake to help them gain more muscle mass. But a lot of times certain health conditions such as kidney disease, you might not be able to really increase your protein intake, so it's good to consult with a physician. So one assessment of nutrition is outpatient screening tool that we use is this screening tool, which kind of looks at different things. So first of all, we can look at the cholesterol level or the blood protein level to see if someone is at risk for developing malnutrition. Also, screening for things like depression can be helpful in assessing somebody for malnutrition as well. So some nutritional issues, vitamin B12 deficiency is something that we see in older folks because as we get older, we're not able to absorb the protein-bound vitamin B12 in the stomach as well. It can lead to symptoms of anemia and cognitive impairment, but the treatment is pretty easy. You just supplement with vitamin B12. But a lot of patients, if you do have a pretty good diet and you eat beef and chicken and yogurt, you probably already get enough vitamin B12 in your diet, and you don't necessarily need to fortify your diet with extra vitamin B12. Your physician can check for this. It's a blood test that you can check for. Vitamin D deficiency is also pretty common because we're not out in the sun. We spend more of our time, indoors. And sometimes also our kidneys produce vitamin D. So if our kidneys are decreased function as we get older, we're not producing as much vitamin D. But vitamin D deficiency, we do see a higher risk in those who are in nursing homes or homebound with very limited sun exposure. So vitamin D deficiency can be treated with increasing vitamin D through our diets, but also taking a vitamin D supplement. So the recommended dietary allowance for adults up to age 70 years old is 600 international units and should be increased after age 71. So in terms of multivitamins, I know probably a lot of you do take a multivitamin supplement, but it's actually not really recommended to take a multivitamin unless you're not already meeting your nutritional needs due to low intake. It might be useful for those older folks who are in a long-term care setting and maybe not getting enough nutrition with their diet. It doesn't actually reduce infections if you take a multivitamin as well. So we do have medications that can stimulate your appetite. These are some of the medications used to help stimulate someone's appetite, include Megace or Marinol, but they do have some side effects to be careful about, so we don't use them for everybody. But there's no medication that is established as beneficial for improving malnutrition, and it's important to keep in mind that depression is actually the most common treatable cause of anorexia in elderly patients. So if you treat the depression, their appetite will get much better. Tube feeding is something that we do see in GI. We do perform procedures to put in feeding tubes in people's stomachs, but it's not really recommended for elderly with advanced dementia because it can often contribute a lot of times to more confusion, agitation. People will want to pull out their feeding tubes, especially if they have underlying, confusion at baseline. So it's not always, the recommended. Careful hand feeding could be offered as a sort of alternative. It is a medical therapy and it can be declined or accepted by a patient surrogate decision maker in accordance to their wishes. It does increase mortality, so putting a feeding tube in someone is not without some risk, but they attribute the increase in mortality with placement of a feeding tube to be more related to someone's underlying medical condition and not necessarily to the placement of the tube itself. So constipation is common. All of us probably have experienced constipation. We tend to see it more in females than in males, and its prevalence does increase with age. As I mentioned before, it's sort of defined as a reduced frequency of stool or having a very hard stool. But it's very interesting because a lot of people don't know that the normal bowel movement frequency can range from having one bowel movement a day to one bowel movement every 3 days. And so that seems like a pretty big range, but it can be considered within normal limits to have a bowel movement once every 3 days. And chronic constipation over time can lead to problems like fecal impaction and incontinence, what we call overflow incontinence, where someone has a hard piece of stool and the liquid stool from above kind of goes over the hard piece of stool, and it looks like diarrhea, but it's actually related to constipation. So we use a Bristol stool chart, and a lot of times I like to show patients this chart because I can have them point to what their stools normally look like. And we want to aim for this kind of nice type 4 Bristol stool scale chart where it's a nice log shape, sausage shape, stool. That's sort of what we consider to be the ideal stool. But in reality, the stool can range a lot. We can have anything from hard rabbit pellets to very liquid stool to soft serve stool. So, it can vary based on what we ate, how much fiber, how much fluids we take in, if we have, a viral infection. So all of those things can change the way our stool appears. So constipation, some causes of constipation can be slow motility of the colon. A problem with our anal sphincter muscle can cause constipation, what we call dysynergic constipation, where people have difficulties with their pelvic floor muscles to have a bowel movement, and irritable bowel syndrome, which is related to stress. So having stress can also affect our bowel movements because the brain and the gut have a very close connection. So a lot of times, stressful situations can cause our bowel movements to kind of change. So some common causes of constipation in seniors include Medication side effects. This is a very common theme today, is medications can cause a lot of GI issues. As well as having diabetes or low thyroid, hypothyroidism can cause a constipation, as well as injuries after a stroke or after a spinal cord injury can cause a constipation. So a lot of times in older folks, there's often more than one cause of constipation. How do we evaluate constipation? Well, we can do what's called a digital rectal exam in your physician's office. So basically, we'll be checking inside the rectum, feeling around for any kind of tumors or any kind of decreased rectal muscle squeeze, and we can tell if there is a problem there. Sometimes we will have to take a direct visualization of the rectum to see if there's any issues going on with the colonoscopy, or we could do a blood test to check for calcium levels or thyroid levels, which can affect our bowel movements. Treatment of constipation, we recommend increasing your fiber intake because a lot of us probably don't eat enough fiber, fruits and vegetables in our diet. The recommended amount of fiber is 30 grams a day. Exercise and being active can definitely improve your motility of the colon, and so that can help your constipation. Drinking enough fluids can also improve constipation. So how much is the right amount of fluid to drink is actually 2 liters of fluid a day, which is 8 ounces 8 times a day, which is probably more than what most of us drink. And a lot of times too, with certain medical conditions, you're on a fluid restriction. So that kind of can make it difficult to get enough fluids in intake. Removal of certain medications that can be constipating can be helpful as well. So what kind of foods are high in fiber? Apples, raspberries, beans. We also recommend like flaxseed, prunes, all of those things can help improve your fiber intake. The other thing that can help with constipation is actually changing the way that you sit to have a bowel movement, because Western style toilets, you're sitting at a 45-degree angle, and really to have a bowel movement, we should all be having those Japanese style toilets where we actually squat, because you actually straighten your pelvic angle and allow yourself to have a bowel movement easier that way. And so there is this contraption called a squatty potty, which maybe some of you have heard about, but it's basically a stool you put under the toilet and kind of helps you bring your knees closer to your chest, so you're able to straighten that pelvic angle to have a bowel movement. Treatment of constipation medically can be things like laxatives, over-the-counter stuff, Dulcolax, Miralax, things like that can help you have a bowel movement. There's certain medications that physicians can prescribe to increase the water secretion into the colon. There's medications like enemas and suppositories that can also help you have a bowel movement. There's actually a physical therapist that specializes in helping patients improve their pelvic floor and their anal sphincter muscle to have a bowel movement that we work with as well. Fecal impaction is basically having too much stool in the colon, and symptoms include constipation, abdominal pain, bloating, and if it goes unchecked, it can lead to colon perforation or poking a hole in the colon or ulcers in the colon. And it's usually related to having a reduced sensation in the rectum and having limited mobility and weakness. And the way that we can diagnose fecal impaction is by doing an imaging study, like an X-ray or a CT scan that can show the amount of stool burden that you have there. The treatment is really disimpaction, so we have to get the stool out. We usually use laxatives, enemas, digital, evaluation to kind of try to remove as much stool as possible. Fecal incontinence is sort of the opposite problem, where we have a leakage of stool. It's pretty common in older folks, up to 27%, and it's due to reduced anal sphincter pressures and altered sensation in the rectum. It's a lot higher condition we see in institutionalized elderly people, and a lot of times patients could complain of diarrhea and might not necessarily tell you that they're having accidents or leakage of stool. It is classified. There's different classifications of fecal incontinence and various causes, everything from having cognitive impairment, so not having the realization that you have to have a bowel movement, to having inflammation in the rectum that can cause leakage of stool, to having structural damage. So unfortunately, women childbirth, when we have children vaginally, that can cause tears in the anal sphincter muscle, which later on in life can cause issues with are able to hold stool in, and that can happen. So how do we evaluate fecal incontinence? I always do a rectal exam in my office to check how the sphincter muscle is functioning. We also have an ultrasound that we can use to evaluate the muscle integrity. We can evaluate the anal sphincter muscle from the inside using a flexible sigmoidoscopy or colonoscopy. We can also do a motility study that checks for the motility of that sphincter muscle. Treatment includes, using Depends, just trying to manage daily life by using enemas or suppositories to clean out every so often, as well as using over-the-counter anti-diarrhea medications, using physical therapy to help with biofeedback and improving your pelvic floor muscles, and increasing fiber intake, actually. And a lot of my patients have seemed to work to decrease their frequency of incontinence of stool. So I always tell patients to really try to take Metamucil or take a fiber supplement to try to see if that works first. The last option would be, surgical repair of the sphincter muscle. Kegel exercises can help to strengthen the anal sphincter muscle, especially for women. So the next topic I wanted to talk about is colonoscopies and doing procedures, gastroenterology procedures in older folks. So the oldest patient that I've ever done a procedure on, I did a colonoscopy on, was 103 because she was bleeding. But, in general, we don't want to do routine screening colonoscopies in healthy, older folks over the age of 75. That's actually what the U.S. Preventative Services Task Force recommends against screening for colon cancer in patients over 75. However, there are a lot of pretty healthy 70, 80-year-olds out there. So I kind of take it by a case-by-case basis. Definitely, if you're 85 years or older, we probably shouldn't be doing a colonoscopy just for screening purposes. But, between 75 and 85 years old is kind of a gray area. In general, the upper endoscopy procedure, where we take the camera and look down into the stomach and esophagus, is usually considered pretty safe and well tolerated, and not as maybe risky as doing a colonoscopy. But really, we never assume a patient is beyond treatment on the basis of age alone. So there can be some increased risks, as I mentioned, with doing upper endoscopies and colonoscopies, aspiration. There's risks with the anesthesia medications. There can be difficulties with doing the bowel preparation, because I'm sure those of you who have had a colonoscopy before, drinking a gallon of fluid to clean out your colon is kind of difficult, especially if you're older, So those are some of the issues that we have to think about, before we do a procedure on someone that's older. The endoscopic retrograde pancreatectomy is done. It's basically how we remove a gallstone that can be stuck in someone's common bile duct, which is draining the gallbladder and draining the liver. And it's a way to get rid of a blockage there, of a gallstone that falls out of the gallbladder and gets stuck in someone's common bile duct. And it's called an ERCP procedure. It is also done by gastroenterologists. It's generally considered to be safer than doing a surgical procedure on older folks, and so we tend to do this procedure to help remove blockages like that. But again, have a low threshold to perform procedures in patients who are symptomatic or who are bleeding. It doesn't matter how old you are, we're going to do it. So that's one thing to keep in mind. So we have some homework for you guys today. So we want you to measure your fiber consumption to determine if you're getting your 20 to 30 grams of fiber daily. If you don't know how much fiber is in a certain food, there's some calculators online and some apps that have that information. We do want you to look at your stools and compare your stools, what they look like, to the Bristol stool chart. It's amazing to me that a lot of my patients don't really look at their stools. I ask them, well, did you have any blood in your stools? You know, what did it look like? And they're like, I just didn't look. But it is important to pay attention and to look and what your stools look like. And also to check your medications to see if any of those could be contributing to any GI issues that you might be experiencing. Okay, any questions?